breathe, breathe, which is a lot easier to be said than done whenever you have someone who's got asthma or other pulmonary disorders. So it could be the main focus of our chat today is making sure that you understand what medication treatments you should be looking for with your patients who have got either asthma or COPD. Here's your learning outcomes. More learning outcomes. And now let's get into the meat and taters of why we're here today. So with the medications that we're going to be speaking about today, one of the things that we need to remember is we need to go back to our charts. Our charts are so incredibly important. They're the ones that help us to remember all this good, fabulous, fun stuff that's actually happening within our midst with our patients. Sorry, I'm turning my light back on over here so I can see what I'm looking at. We're looking for medications that actually help to stimulate the sympathetic nervous system, because when the sympathetic nervous system gets stimulated, it's going to dilate the bronchioles. And that's really what these patients need, is they need their airway to go from being closed to being open. So we would want to avoid drugs that are going to stimulate the parasympathetic nervous system and going to cause that bronchial muscle contraction or bronchoconstriction. So any medication like that, we would want to avoid for our patients if possible. And we'll talk about the reason why the if possibles later on as we go through the lecture series. In this particular instance, you may want to think about that medications that are considered beta blockers may be contraindicated in patients with asthma or with COPD. All right. Let's see what's good. So one of the good things about patients with asthma or COPD is our ability to be able to give the medication at the direct source, right where it's really needed. The alveoli and bronchi are really, really rich blood supply. So because of that, the medication, if we give it by inhalation, it gets to this receptor site super fast and we can get some super quick results with that. The problem we have is that a lot of the times, no matter if we're giving nebulizer, dry powder, or a meter dose inhaler, it is really dependent upon the patient's ability in order to actually get that medication where it needs to be. So because of that, patients who are very young or patients who are elderly and have a low cognitive function may not be able to be as coordinated as they need to be. Because you think about it, you gotta like have the inhaler, put it in your mouth, hit the button, and take a deep breath in all at the same time. So again, for our cognitive function patients who are not cognitively, who may be cognitively impaired, this may be a function that they really can't do very well. One of the things that we will do for children is nebulized medication tends to be better tolerated in that population, but the downside is you can't take a nebulizer with you wherever you go, so an inhaler is actually easier. The nebulizer tends to have more of an opportunity for that patient to get the medication into their lungs because we're going to be breathing it over several minutes, but that takes longer. And if you've got a small child who's just fidgeting and fidgeting and fidgeting, then that may not be the best way to give their medication. We do want our patients to get into the habit of every time after they take their inhaler, their nebulizer, we want them to rinse and spit. Rinse and spit, not rinse and swallow, rinse and spit. The reason is because inside of their mouth, there's a lot of residue from the medication that we were just giving, and it's hanging out on the mucosa. If it hangs out there long enough, we could eventually get some systemic effects from an inhaled medication. The other thing is too, is that sometimes the medicines that we give via inhalation can be a steroid. Having those steroids on board in our small children could actually lead to like growth retardation. They could also lead to an overgrowth of bacteria in the mouth. So having your patient rinse their mouth after every single breathing treatment, really important. Asthma. Asthma is considered a chronic condition. It has bronchospasms and inflammation and swelling in the lungs that leads to breathlessness. Most of the time that this is actually caused by a trigger, by something in the environment, something that this person gets in contact with that will kind of set off their inflammation cascade. We have a couple different strategies for control. We have quick release strategies and we have long acting strategies. I will tell you that there is a link here. It's called the Stepwise Guidelines for Asthma Care. And it is about a 14-page document, but it is so incredibly helpful. It tells you, it says if your patient is having to use their short-acting inhaler for X number of times per day, week, or wakes up at night with any kind of breathing treatment, that we need to step them up to therapy, to a different level of therapy. So I highly suggest that you go in and you look at the guidelines and then think about the patient that you may be seeing in your practice that's coming in with asthma all the time. When we work in the hospital setting, in the emergency department, or on the floor, we see these patients, man, they keep coming back for exacerbations. Why? It's because they may not be on the right therapy. So as nurses, we can advocate, if we know the guidelines, we can advocate for our patient to be on the best absolute therapy. Like I said, 14-page guideline, super helpful. Go take a look at it. You'll really appreciate that you did. This is one of those things, if I was a student, I would probably create a folder on my computer and I would write respiratory, and then underneath that folder, I'd give it that category of asthma, and I would save this document into that folder for future reference. Because as you get into nursing school and as you go on into your healthcare career, you're going to encounter asthma over and over and over again. Understanding how these meds work and then understanding how that they're supposed to be treated can help to make your patient much healthier. So we, meaning providers, would appreciate your help on that. So first category of medications. I'm looking at my sympathetic nervous system. I've got my chart in front of me because I don't go anywhere without my chart. And I can see that an agonist response, so something that was a beta agonist, would actually help to dilate my bronchioles. Now, I will tell you that when we talk about beta agonist medications, we have ones that are both selective and non-selective. Can you do a quick review in your mind about what selective versus non-selective means? Okay, good, that was fun. Fabulous. So selective means it's only going to hit one receptor site versus non-selective, which means it might hit all of the beta-2 agonist sites. So our beta-2s are located in our lungs. Ooh, I can't see what I'm doing. Located in our lungs, located in our stomachs, located in our uterus, located in our liver. So maybe not too bad if we were to have a non-selective beta, a selective beta. But what if we had something that was a non-selective beta, that it was going to activate all of our beta receptors? This is where we as nurses have to really think about this, because if we have a patient who has, let's say, some sort of a heart disease on top of a lung disease, this could be detrimental if we're giving them a non-selective beta blocker. If it doesn't just activate the beta selector, the beta-1 agonist, if it starts to activate both the beta-1 and the beta-2, and let's say this patient has a heart condition, that can be a huge deal. So understanding your patient's past medical history, what's going on before we allow a doctor to order a medication or we administer a medication to a patient that's been ordered, very important. We have two different types of beta agonist drugs. I will tell you that we have a short-acting and a long-acting. You're going to see a lot of short-acting beta agonists out there. You're probably not going to see as many, well, I shouldn't say that. You're going to see both SABAs and LABAs out there. I will tell you that getting our patients to comply with their LABAs can be a difficult undertaking because they don't quite understand what the LABA is used for. When the LABAs first came out, we all were like, woohoo, we're never going to have another asthma attack. We're never going to have any problems with COPD ever again. And the patients got confused, and maybe the healthcare educators got confused too. But one of the things that was happening is that they gave these LABAs to these patients, these long-acting beta agonists, and the patient was like, I'm short of breath, quick, hand me my LABA. That was the wrong thing to do because it can take up to an hour to actually physically work on the patient versus our SABAs, which, boom, you get almost instantaneous relief. But the effects were short, only lasted 2 to 6 hours. So the LABAs are more for our long-term management. We don't want our patients in an asthma attack or a COPD attack with an O2 sat of 80% reaching for a LABA thinking that that's going to help them. Instead, this is kind of more of a long-term, every single day kind of thing versus the SABA, which is a short-acting, going to get me out of a issue right now. Albuterol is probably the most frequent one that you're going to see out in practice for the SABAs. With the leva albuterol, that's also known as Xopenex, With the Xopenex, one of the things I like about it is that it is more selective to beta 2 agonist than albuterol is. When I give a patient a short-acting albuterol, short-acting bronchodilator like albuterol, one of the things that I find is that those patients tend to get pretty tachycardic and they get nervous and they can't like sit still because it's activating more of their receptors in their body. The Xopenex tends to do that less. So for a patient who has heart disease or who you're worried about increasing their pulse rate, going with leva albuterol, aka Xopenex, may be a better thing than going with albuterol. Sub-Q terbutaline, I almost didn't even put this on the slide, but I want to let you know that sometimes our EMS providers carry this medication as one of their treatments for a patient who has asthma. So sometimes they'll come in, they're like, yeah, we gave them some sub-Q terbutaline. It works really well, but again, it tends to be non-selective. So it's hitting all their cardiac receptors and can make the patient just really like, makes them very jittery. So it can be an issue. Also too, beta 2 adrenergic agonists, we do have a PO version. There's an albuterol 4 milligram, 2 milligram, or a 4 milligram tablet out there. We get a longer duration, but again, now we're taking a pill that's going to go through all of this that really just needs to be right here in my lungs. So we get a lot more systemic effects from that. I will tell you that over time, if we keep using beta agonist, adrenergic agonist over and over and over and over and over again, we do get a tolerance and then we have to increase the dosage of it. This is the reason why we have this stepwise therapy for asthma. We have the same thing for our COPD patients. They have a plan to say, if this isn't working, we need to do this. And if that's not working, then we're going to do this. And if that's not working, we're going to do this. It's a plan because they know that tolerance can happen. I deal with a lot of patients who are low socioeconomic, low cognitive functioning. I have found in the community, there's one individual, young guy, he needs to be on step number 2 or 3 of the asthma therapy. He needs an inhaled corticosteroid. He needs a beta agonist. He probably needs a LABA. The problem we have is a couple things. Number 1, compliance. Number 2, getting him to pay for it because these medications are very expensive. And then number 3, compliance. So having compliance issues with patients is probably one of the biggest things that we're going to do. My concern for him is because the number of times that he's come in status asthmaticus is that if he doesn't start following this stepwise therapy that's been recommended for him, that eventually we're going to get to the point to where we can't pull him out of it. So scary, scary stuff. Another medication that we will use for our patients is anticholinergics. Okay, anticholinergics. Ms. Hardy, what happens to an anticholinergics? No problem. I grab my chart and I'm looking at my chart and I go, okay, what does an anticholinergic do? So here I am looking at the anticholinergic. Boom, hits the muscarinic receptors and dilates the bronchioles. Yep, that's exactly what a patient with asthma would need. So with this medication, typically what it does is that we use this medication as an adjunct with our beta 2 agonist. So sometimes we'll find ipratropium, sorry, I always call it Atrovent because it's easier to say. I'm going to do my best to pronounce this for you. The ipratropium, we add the ipratropium to albuterol and we put them in the same little bullet together to give to into the nebulizer. And it works fabulously better. Like, it's just better together, sister. So with that one, the DuoNeb, we tend to use those on patients who come in who are having an asthma attack. We'll give them that, and usually it'll kick them out of having that attack. It's that two combination therapy, and they really help to synergize each other. We also have another anticholinergic, tiotropium, also known as Spiriva. It's very similar to ipratropium. However, it is way more costly. Like, let's talk like $300-400 a month more costly. So when it comes down to compliance, sometimes it comes down to what can the patient afford. My patients can afford the ipratropium, we'll go with that. Like I said, typically whenever we start prescribing this medication, you'll see it as something called ipratropium and albuterol. It'll be together. They can get it in an inhaler. They can also get it for the nebulizer. Methylhexamines. So this is the way that your nursing instructors, because we're all older than dirt, all learn how to treat patients who had severe asthma or patients who had severe COPD. However, this medication has a very, very narrow margin of safety. And because of that, we have to draw lab work on this patient all the time. We don't traditionally see this in medicine right now. I say that. And then I went to a patient's house the other day to see them because they were having a COPD exacerbation and they had theophylline. I'm like, okay, maybe it's coming back. I wanted to point it out to you because you're going to see it. Nursing instructors tend to like to pick on this medication because it does have a narrow margin of safety. What I want you to put in your brain is that theophylline has a drug range. It's 10 to 20. Okay, so if we were drawing labs to see how much of it was in the system, the therapeutic range is 10 to 20. Over 20, they get toxic, and so all those adverse effects, they just multiply and get horrible. All of a sudden, you got a patient coming in and they got the weirdest, funkiest heart rhythm you've ever seen. They may be because they're taking too much theophylline. With the theophylline, you can give it PO or IV. Like I said, we don't really see this in practice that much. If you have a patient coming from another country, it could be that would be the therapy that they're putting them on. So just to have your eye on the prize and that you understand that theophylline still is out there. It's chemically related to caffeine. It helps to cause bronchodilation, but again, has some really wicked side effects and a narrow margin of safety. Corticosteroids. Corticosteroids help to decrease the inflammatory cells and helps to decrease and then increase the things that prevent the body from actually overreacting. The other thing it does is it helps keep the mucus in check so that you don't have all this like gooey stuff running around the lungs, clogging up the space so that you can't get air in and out. And then also it will help to decrease edema. If we had our preference on these patients in our stepwise therapy, we would use an inhaled corticosteroid every single day. If they don't use it every day, it doesn't really help a bunch. If they wait until they get sick, we're behind the game. So instead, we need to recommend the therapy to be done every single day when it's ordered. In our stepwise guidelines for asthma control, so step 1 being just taking a short-acting bronchoagonist like albuterol. Step 2, this is where this starts, corticosteroid, an inhaled corticosteroid. Our inhaled corticosteroids come in different potencies or different potencies. So we have a low potency, a medium potency, and a high potency medication. So typically we do this in a stepwise therapy as well. We won't start them off on the biggest and the baddest. We start them off on the smallest and the least and then see how they react. Once we get that therapeutic effect that we're looking for, that's the dosage and the medication that we're going to stick with. Always understanding that if for some reason that medication seems not to be working, we're not getting the therapeutic effect, we're having multiple issues with shortness of breath at school, we're waking up in the middle of the night with shortness of breath, we're coughing all night long, we may need to step them up on the therapy ladder in order to get them where they need to be. So just remember that with asthma care, it's always a step therapy. Now, once we get to a certain level, we may, and that patient's stable, then we may start to step them down, okay, once they get to be more stable and see where they go. We get them up as high as we need to do to reach therapeutic effectiveness, and then we're going to step them down to try to get them on the lowest dose steroids possible. This becomes really important when we're dealing with children. When we deal with children, one of the things that can happen is growth retardation if we keep giving them steroids and steroids and steroids and steroids. They don't grow right. Our diabetics, if we keep giving them steroids and steroids and steroids, we're going to increase their blood sugar. We don't need that in our diabetics, okay? So what we have to do is we do this step up and a step down therapy, and we're always trying to figure out where on that continuum does that patient need to be today in order to have the best effective therapy possible. If our patient comes in and they've been on inhaled steroids, and let's just say that now they have an acute exacerbation, they're so much worse. Their pulse ox is down, their wheezing is down, they're taking all their treatments, and we just can't get them out of it. Sometimes what we do is that we will give them additional systemic steroids. That's right, it's going to go all over this, and get them out of their exacerbation. So I'll tell you how it usually works for me. As an emergency room nurse, what would happen is the patient would come in having an exacerbation, wheezing, dyspnea, coughing, pulse ox maybe from like anywhere between 93 and 80%. And the first thing we're going to do is we're going to start an IV on them. And if it's an adult patient, we're going to give 125 milligrams of Solumedrol. That's a corticosteroid. We're going to push it in. If for some reason I'm in a patient's home and I don't have an IV, but I have steroids, I can give them 125 milligrams IM. Same thing. The other medication that we would use for this one is called Decadron. And for the life of me, the generic name of that one has like totally completely escaped my brain. But what we'll do is we kind of just hit them with that IM or that IV dose, and that kind of helps to throw them out of their issue. I'll tell you guys, it's amazing. You give someone these medications IV or IM, within 15 minutes, we've got instant reaction and instantly getting better. If they're not instantly getting better, I'm looking for a freaking provider to like, come on, you better get in here and intubate this patient because we're not losing anyone today, okay? Then the next thing we're going to give the patient is an oral medication. We're going to give them a couple days worth of an oral steroid to take at home. And usually we do something called a tapering dose. So what we'll do is we'll start on day number 1 and we'll give them like 60 milligrams. And then day number 2, we'll give them like 40 milligrams, then 20, then 10, then 5, and we taper them down. Everyone kind of has a different tapering schedule, but for the most part, that's kind of what everyone does. And I apologize, I was supposed to say oral. When we give frequent systemic steroids, these are the issues that we have. The adrenal gland is supposed to be producing epinephrine, is supposed to be producing a lot of these hormones in the background that keep you going. When we put steroids in the body systemically, your adrenal gland gets really lazy. It's like, oh, well, if their epinephrine's going to show up here for the day, then I'm not coming to work. So you can get the adrenal gland will actually atrophy and then doesn't work anymore. And then this patient goes into an adrenal crisis. So we don't like to give corticosteroids, IV, IM, or oral multiple times or for long term because of that, of these issues. So our goal as nurses is to look at this patient and go, okay, I'm listening to what these symptoms that you're saying. It doesn't sound like our asthma is well controlled. Let me make a recommendation to the provider about where you're at in your therapy. I'm looking here, and the only thing you had for your asthma to treat it was just Proventil. Yeah, I think we can do better than that. Okay, and that's how we help the patient to get to the most optimal therapy with this medications. Leukotriene modifiers. Leukotriene modifiers play a pretty big deal in the management of asthma. What these medications do, so first off, let's talk about what leukotriene does. So leukotriene is kind of like the guy, he's like the really irritating big brother that institutes all the fights, okay? So that's what a leukotriene modifier does. It starts a lot of fight. It actually starts the allergic reaction. It can start setting off mast cells. So we figured out that if we just block this guy or turn him off, that we can prevent a lot of inflammation, mucus production. We can prevent the immune system from overreacting. Okay, so what we do with this medication, there's 2 different ones. We have something called Zoloton, also known as Zyflow, which is nice because Zyflow, air flows. It's a controlled release tablet. It works within 2 hours of giving it. The problem is, cha-ching, 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 it's expensive, okay? The other medication, it's been on 2 other leukotrienes, been on the market for a long time, Zerfiloculast, also known as Accolate, and Montelukast, known as Singulair. Both of these block leukotrienes. Problem is, it takes a week for it to start working real well, so definitely not an acute medication. With the accolade and the singulair, you got to watch their liver enzymes and be very cautious. If your patient, all of a sudden you're like getting your history from your patient and you say, so do you drink? And they're like, yeah. And you're like, okay, well, what do you drink? Well, I have alcoholic beverages 6 times a week, and I drink liver, and I drink tequila every single night, and blah, blah, blah. This is not the medication for them. This medication is mainly metabolized in the liver, and so because of that, they can get toxic on it. So be listening for that history. If you hear that and you're like, oh, I need to tell the doctor that this guy's a drinker. Okay. It could also be a lady drinker too, but just be sensitive to your patients. Okay, be listening. Leukotriene modifiers. When we're talking about stepwise therapy for our asthmatic patients, it's step number 2. Okay, so step number 1, short-acting beta agonist. Step number 2, you're either going to give them an a corticosteroid for inhale, or you're going to give them singulair, or you're going to give them cromolyn, which is a mast cell stabilizer, which we'll talk about next. So with the mast cell stabilizer, these are pretty old drugs. We've had these around for a really long time, and I'll tell you that they've kind of fallen out of favor. However, in our asthma stepwise therapy, this is now step 2, okay? If the short-acting bronchodilator is not working, we go to step 2. We're going to give you your short-acting bronchodilator plus your inhaled corticosteroid plus either a mast cell stabilizer or a leukotriene modifier. That's the treatment plan, either one of these. This one is an inhaled medication, so you have to sit down and you actually have to nebulize it or have an inhaler. So sometimes we don't always get as good of compliance as we do versus just popping a pill. The other good thing about the leukotriene modifier, especially with singulair, is they actually developed a chewable tablet, which was fantastic for our kiddos. So again, kind of a weird drug, this mast cell stabilizer. You may start to see it in certain populations of people reappear, which is the reason I wanted to bring it up to you. The other thing about cromolyn, this mast cell stabilizer, is that it's also used for things other than just asthma. So you may see it used in allergic rhinitis, allergies. Okay, that makes sense to me. But it could also be given for a rare disease called mastocytosis. There's not a lot of information on the internet about mastocytosis, but basically what happens is you have patients who have mast cells that have just gone wild. And so they give this medication to them. Also, there is a PO version of this for mastocytosis, and also it'll treat ulcerative colitis and food allergies. So again, you think about what mast cells do in the body. They wreak havoc and they turn on your histamine and all this other fun stuff. So this may be one of those medications that when you see it, you need to dig a little deeper and don't just assume that they've got asthma or COPD or something. Monoclonal antibodies, man, so monoclonal antibodies are so freaking cool. They're made from rat parts. I mean, it's just awesome. But what we know about monoclonal antibodies is that they work completely different than a lot of the other medications that we do. And we're going to learn more about those when we talk about medications for infections and cancers and so forth. These will actually alter the body's ability to do things. So yeah, pretty stinking cool when we talk about monoclonal antibodies. We have one set of monoclonal antibodies that we give to patients who have allergic reactions. And I apologize, I did not put the name of it in here. It's called omalizumab. It is a sub-Q injection. You give it to the patient every 2 to 4 weeks, but then it has some dirty side effects. Anaphylaxis, it can cause your periods to become more painful. What? Yeah, there's a reason for that. It's pretty cool. We'll talk about it later. Rash, headache, and then of course you have an increased risk of viral infection. The other issue that you have is that this little treatment, $355.94 a month. So not everyone's going to get to participate. COPD. So just like with our patients who have asthma, our COPD patients also have standards of care. So I provided a little link for you here so that you can go and check it out. So what COPD is, it's a chronic progressive pulmonary disorder. It's chronic obstruction of our airflow. And a lot of times the two biggest issues that we're fighting here is going to be mucus production and inflammation. So with these patients, as it progresses and we get further and further along in how long this disease is, eventually the little alveoli, the little sacs down at the bottom of the lungs, they eventually just dilate, stay open, and can't close and open again. They lose their elasticity. So basically what you have is you have a balloon that should be, our alveoli should be doing this, right? So what happens is eventually their alveoli just stay open, and then they don't really move that much to get that much air in. I have a very sweet little 85-year-old patient that I'm currently taking care of, and she has end-stage COPD. She can walk from her bedroom to the front parlor less than 25 feet. It's a very tiny house. And her O2 sat, when she takes off her oxygen and then has a seat down in the living room, will drop into the mid-80s. And she tries to breathe, but basically her alveoli, because they're so dilated, they don't take any more air. So she's trying to take in air and it just doesn't do it. Versus if you and I were to do it, our alveoli would collapse and pull in, collapse and pull in. Hers don't do that anymore. So when you listen to her breathe, there's not a lot of air movement. So the gold standards tell us how sick the patient is. They're graded 1 through 4, with the highest score being the worst. And it's based upon a whole bunch of factors. When we're diagnosing a patient with COPD, they have to have something called a spirometry test. Not a pulse ox, but a spirometry test. It's a device that they put on, they clip off their nose and they put this thing in their mouth, and they take a deep breath in, and it gives us a number. The lower that number, the worse the patient is. So like you and I right now, we're sitting here with a ratio, an FEV1 to an FEC ratio of greater than 80%. These patients can have that same ratio, but it'll be less than 30%. So when they get 70%, less than 80%, they get a diagnosis of COPD. And then when they're at their worst, it's less than 30%. So these patients get very sick very quickly. Good news, bad news is all the medications that we use to treat for asthma are also the same medications that we'll use to treat for COPD. With the gold standards, they give us the ability to look at a patient and say, based upon how you're doing, your gold standard, that tells us the type of therapy the patient needs to be on. Is it a SABA plus a LABA plus a long-acting muscarinic antagonist plus a short-acting muscarinic antagonist plus an anticholinergic? What do they need? So the gold standards really help to define what therapy a patient needs to be on. But again, think about them same way you think about your asthma patients. They're on a step therapy. If this doesn't work, then we're going to do this. When this stops working, we're going to do this. When this stops working, we're going to do this. Ultimately, all these patients will eventually be put on oxygen therapy full time because their O2 sats will become so incredibly low that they will not be able to function. We can actually decrease their mortality by putting them on oxygen. It makes them not have to work as hard to get that air in. One of the key things that I see with COPD patients, especially when the further we go in to the disease process, is the metabolic demand for their body is so incredibly high. This lady that I'm talking to you about, she is 5'8" and she weighs 79 pounds. Her metabolic demand just for breathing is so incredibly high that she has to consume more, she needs to consume more calories, or else her body is going to decompensate. And we're working with her, we're giving her some insurance and stuff like that, but she's 79 pounds. Her BMI is like 16.5 or something crazy, totally completely undernourished. And it's not because she's not trying to consume the calories, just so much of her work and her effort is going into physically breathing. And because of that, she's losing the weight. Okay, nursing process. So what do I need to think about when I have a patient who's getting these medications? It always starts with my health history. I'm looking at this patient and going, why are you so short of breath today? And I'm looking for things like asthma, COPD, emphysema, those sort of things in order to kind of put those all together in my brain. I'm looking for, have they ever had surgery? Can you imagine if a patient was missing part of their lung because they removed it from some sort of a disease process? Are they pregnant? Are they breastfeeding? How are these medicines medicines I'm fixing to give them, are they going to go through to the baby? Are they going to go through the breast milk? Are they going to hurt the baby? Always thinking about that. Smoking. Don't ever start smoking. If you're smoking right now, please stop. Okay. Unfortunately, tobacco products, vaping, these are the things that are actually ensuring that I have a job from now until, I don't know, forever. So it's real important that if you are smoking that you stop, because some of the effects are reversible. Caffeine, drugs, what are you smoking? Okay, if you're smoking marijuana, I need to know. Okay, I tell people this all the time. I'm like, look, you're not going to get in trouble. I just got to know. If you're smoking, I got to know because it is going to affect their lungs. Baseline vital signs. What did this patient look like before I do anything? Okay, and then labs. We talked about that there's one medication that really affects the liver. So you got to watch it and make sure that those liver enzymes, which are considered your AST and your ALT, there you go, are not elevated. And then once I give the medication, I need to reassess this patient. Am I getting to that therapeutic effect that I intended with that medication? I always repeat my vital signs at least 30 minutes after any dose, sometimes faster than that if my patient wasn't stable to begin with. If those vital signs are whacked when I started, I need to take them until I am sure that they're not going to go whacked, keep getting whacked, okay? And then adverse effects. I need to tell my patient that before I give them albuterol, hey, this can make you feel nervous and jittery, okay? All of a sudden, they feel like they're going to levitate off the table and you didn't tell them? Shame on you. Again, watching that medication as we're going through, am I getting to that therapeutic effect that I want? And is there any safety concerns? Not anything that I need to tell this patient. Do not operate heavy machinery. Do not drive a car. Do not drink alcohol while you take this medication. Before you get out of bed, I want you to call me. I need to be here with you before you get out of bed. Those sort of safety concerns. When I'm thinking about giving medications in the IV, I need to be thinking about, is there a problem? What happens if this medication comes out of the vein and gets into the local tissue? Is that a safety concern for me? So that's the nursing process that I'm going through as I'm giving these medications. All right, guys. Hope you liked the lecture, and we'll talk to you guys on the next series.